Okay, so next we're going to explore where science is headed in relation to how remission might look like for people living with asthma. Dr. Blaiss is a clinical professor of pediatrics at the Medical College of Georgia and the executive medical director at the past director of the American College of Allergy, Asthma, and Immunology, past president of the organization. He's a world recognized leader in asthma care and has published more than 120 peer reviewed papers and has presented his work worldwide. Welcome, Dr. Blaiss.
Thank you.
Oh, better.
Oh, okay. This one. Okay. Let's see if I can hold two things at the same time.
And if not, I can.
It will do it. It's hard. So good afternoon. It's great. You hear me? Okay. It's great to be here. I thank the Allergy Asthma Network for this kind invitation. And I may be a little controversial today, which is nothing new. And I'm going to talk about asthma control. We'll look at biologics. And in fact, we'll look at remission asthma. So just real quick before I start, how many of you have heard anything about remission in asthma? Okay, everything you've heard is wrong. Okay? And I'm going to tell you why. Okay? Good. So these are my conflicts of interest for this particular lecture. I'm not going to discuss specifically anybody's products, anything like that. So I've got three things I want to cover, and I know I have limited time, so I'm going to go fast. But I want you to understand the differences between asthma control, which is what we've been talking about since the 1970s, and what people, in fact, are saying is asthma remission. And then I'm going to look at some of the data related to biologics, because that's probably where you've heard the term asthma remission. I'll tell you why. Be very careful about that at this point in time. And lastly, a paper that I was part of, along with about 14, 15 other allergists and pulmonologists, was the joint consensus statement of the American College of Allergy, Asthma, Immunology, the American Academy of Allergy, Asthma, Immunology, and the American Thoracic Society on the term of remission on treatment in the asthma population. Okay, so let's start with something we do talk about a lot and really have a clear definition of, and that in fact is asthma control. So again, when did we start using the term control? In fact, it was back in the 1970s when we really started to understand that asthma was more than just a disease of bronchospasm, but in fact had underlying inflammation. And that led also to the development of inhaled corticosteroids at that time, with its effect as far as controlling symptoms and exacerbations by the use of treating the underlying inflammation. And many of you are probably familiar with the rules of two as a way of determining, in fact, if a patient has asthma control. I mean, I still ask those questions on a regular basis to get an idea of how well my patient's under control. And then we have the GINA guidelines, so the Global Initiative of Asthma, and this is from 2025, but it hasn't changed for about the last 10 to 15 years. And it talks about two domains, again, first being symptom control, and then future adverse events. Okay, so what are the questions that we ask here to find out if our patients are under control? Very importantly, I want you to look here that it says in the past 4 weeks. So remember that as we go along. So control we ask about in the last 4 weeks. So you have daytime symptoms more than twice a week, nighttime awakenings due to asthma, using a reliever more than twice a week, any activity limitation asthma, and they talk about well-controlled, partly controlled, and uncontrolled, depending on the answers. So that's what, again, I think a lot of us use as far as monitoring patients to determine how well they're under control. And then future risk really talks about the role of spirometry and measuring lung function, like the FEV1, the forced expiratory volume in 1 second. We know that the lower that is, the more likely you are to have an asthma flare-up. So it's a way of trying to predict the future and trying to prevent a bad exacerbation. Okay, so that is control. Okay, so now we're going to move on a term that's been used now for about the last 5 to 6 years in the United States and certain areas around the world, and that is talking about asthma remission. All right? Okay. When I hear the word remission, the first thing I think about is cancer. Okay, right? I mean, that's where, we hear the term, my cancer's in remission. So we have the definition here from the National Cancer Institute. So it's a disappearance or a decrease in the signs and symptoms of asthma, of cancer. Partial remission is a decrease of some of the signs and symptoms, and then complete is all the signs and symptoms, but it doesn't mean that the cancer is still not somewhere in the body. Okay? And then we also have a definition for type 2 diabetes. And again, in this case, they talk about, again, blood work having to become normal, the hemoglobin A1C, and that either was spontaneous or with intervention. But also in their definition, you have to be off of all medication for type 2 diabetes for at least 3 months before you talk about remission. Okay, so in their definition, you have to be off of medication. And then you have rheumatoid arthritis, which also has a definition that's accepted. And that, in fact, is 1 or fewer swollen joints, 1 or fewer tender joints. Ask the patient about their arthritis activity, a blood test to look at inflammation. And again, the patient can, in fact, be on medications and, in fact, be listed as far as in remission with rheumatoid arthritis. Okay, so the question has been, are we at a stage yet in asthma with the treatments we have? Can we really talk about remission? And then how do you define it? All right, so here's a polling question. So which of the following is a type of asthma remission?
Last poll of the day, right? I want to see 100% participation. All right.
Okay.
Almost there, almost there.
So it's all the above. It's a trick question, okay? Yeah, people are using these terms. I'm just not convinced we are there in any of these terms with asthma, okay? So here's what they're using as far as some of the definitions here. So we got clinical remission on treatment, in fact, is the one that if you look in the literature and you're reading when people are talking about this drug is leading to remission in asthma. So they're talking about no symptoms, no exacerbations, and sometimes normal lung function. Complete remission, which in fact, we definitely don't have any evidence of, and that in fact is normalization of asthma pathophysiology with the other 3. There's no data on that with anything presently out there. And then inflammatory remission is normalization of biomarkers, and that's not clear from any of the treatments yet either. All right, so this is the most important slide I'm going to show you, because the first thing you've heard about remission, there is no standard definition throughout the world as far as asthma remission. They're all being made up right now by different groups, okay? And some of it by pharmaceutical companies. And the bottom line is there is no standard. And until we get a validated measure, I think we should not be using that term asthma remission with anyone, okay? Because the first thing I think of, again, with remission, it means the patient can come off of medicine. And nothing could be farther from the truth, at least in 2025. Okay, so how do we assess it? What should we be looking for if we're going to say a patient is in remission with asthma? So one is clinical symptoms. So does that mean sustained absence of symptoms? But for how long? Does it mean 6 months? Does it mean 1 year? Does it mean longer? Okay. 2, what about validated instruments that measure asthma control? So we have the asthma control questionnaire, which is the one that's used primarily around the world, but there are 2 standards of control. There's a less than 1.25, and then there's a 0.75. 0.75 is more control. Okay, and people are using the different measures. And then we have ACT greater than 20, but I'll tell you in Japan, they use greater than 23. out of the 25 score, okay? And then we have the air Q less than 2. And so what do we mean by no exacerbations? Does it mean no steroid burst? Does it mean no ED visits or hospitalizations? Or should you add no unscheduled office visits due to asthma? Okay, that's a much higher standard. Or should you add no missed school or work due to asthma? That's a much higher standard. Okay, I will tell you, nothing that you're reading right now when you hear a drug causing remission uses those last two standards. Okay, and then lung function. Does it have to be stable or does it have to be normal? And then what is normal? Is it an FEV1 greater than 80%? Do you have to show improvement in lung function? Okay, so we have all of that. And then do you require, what about medication? In other words, do you have to show a decrease in medication or not? In other words, can you still stay on high dose inhaled corticosteroids, which we know have side effects, and yet still be in remission? Okay, and do you have to show a decrease in rescue inhaler use? I will tell you that all the studies you're seeing right now out there that are saying a drug causes remission, none of them are looking at rescue inhaler use. In other words, you can use as much as you want and still be in remission. Okay? All right. And then normalization of asthma pathophysiology. Normal levels of biomarkers. You have to show a negative bronchoprovocation. You have to do a biopsy and show, in fact. So again, no one knows the answer. I mean, there are different people in different groups, as I'll show you, are putting things together, but there is no standard like we have for asthma control. Okay, this was a paper that kind of started it all. So a few years ago, 2020, Gao was the first author. So this included primarily European and American allergists and pulmonologists. So what they talked about was sustained absence of significant asthma symptoms based on a validated instrument, but they didn't say which instrument. They said optimization, stabilization of lung function, but they didn't give a definition. They said patient and healthcare provider agreement regarding disease remission. I don't know what remission is. I don't know if I should expect my patient to know what remission is, at least at this point in time. And no use of systemic corticosteroid therapy for exacerbation treatment or long-term disease control, which I think is the only thing that all of us tend to agree on. All right, so, but that started it all. So then we started seeing studies coming out. And so this is from a paper now a couple of years ago that was in Chest. And what this is mostly what's called post hoc analysis. So these were studies already done. Then they went back and looked at different criteria and looked at their particular drug as far as the degree of remission. So you'll notice here, the thing I want you to notice here is they're looking here at absence of symptoms. But again, they're all using either sometimes 1.5, sometimes 0.75, some are using the ACT. And then if we look at lung function, again, some are using lung function, but at different measurements. Some are not even including lung function. And then others, they're all no exacerbations and no steroids. And so you see these prevalence rates. You see for this drug here, it looks like 43%. That sounds pretty good. But again, they're not looking at lung functions here. And then you see others here that may be as low as 14%. So everyone's using different definitions. So you can't compare one particular product to another particular biologic because, again, everyone, it's the wild, wild west out there for remission. Everybody's using different definitions. Okay, and I'm going to come back here and talk about this study. And this is the Danish registry, and it looked at different biologics. Okay, so I went back, because I had nothing else to do, and I did a post hoc analysis on 3 of the drugs that, and also I didn't say on the other side, some of those drugs only looked at 6 months data. They didn't look at 1 year data. So these were 3 that looked at 1 year data. And what you see here is, again, this one used the higher standard for asthma control, 0.75. This one did 2. This one, though, used the less standard of 1.5. Okay? Then we have different definitions again here for improvement in lung function. This one was an improvement of 100 milliliters. This was a change of greater than 80%. This one used two different definitions. Again, none of them were on maintenance steroids or had steroid burst. So again, we see differences here, 14.5, 20%, 12.7%. So this one's lower. Why is that one lower? Main reason is they added two other measures here, having both the patient and the healthcare professional grade the patient's severity. Okay? So again, we're not measuring, or no one is using the same measures, and it makes it very confusing. All right. So this is a Danish study, and what's interesting in Denmark is that every patient, adult with severe asthma is placed on a biologic goes in the government registry. So they have data on every asthmatic, again, that is placed on a biologic. So they can look at their data, which makes it really interesting. Okay, so they made up a definition called clinical response here. Okay, and their definition was a 50% reduction in exacerbations and or 50% reduction in steroid use. Okay, then here was their definition for clinical remission. 12 months, no exacerbations or maintenance oral steroids, normalization of lung function. So it had to be greater than 80%, and they used the less standard ACQ6 of less than 1.5. So not really what I would consider, again, very strong measurements, but that's okay. So we'll look at the results. And this may be hard to read, so I apologize, but I'll go over it. Okay, so in this registry, they had about 500 adults that were on biologics. And what you'll see here is that 21% had no clinical response. So they did not respond to that particular biologic. And that's kind of what we see, all right? So not everybody responds to the first biologic they're given. So 79%, as you see here, in fact, did show a clinical response. Now, of that group, what made their definition of clinical remission? And in fact, out of this total group, it was 19% with that particular definition. Right. They use the same criteria that we use in the United States as far as determining a patient that qualifies for a particular biologic. So if you look at anti-IgE therapy, they have to have a perennial allergen positive skin test and symptoms on exposure to that allergen. For the anti-IL-5s, high blood IgE levels, and for the anti-IL-4 alpha drugs, high blood eosinophils and or a high ENO. And so what they did here is they looked at it. And again, we're still not measuring, so they have different criteria to go on the biologics. But if you look at the anti-IgE, at least in their study, 6% in total went into remission. The anti-IL-5, 19% went in remission. The anti-IL-4 alpha 30% went in remission. But the point being is, it's not a very rigorous definition, at least in my opinion, as far as what I would consider being a remission. Remember, they're not looking at albuterol use. They're not looking at any decrease in medications. Okay, so what we're seeing out there in the literature, though, is that some people are using just a 3-component definition. So no or little asthma symptoms, no steroid use, no exacerbation. And so we're seeing very high levels of remission when they're just using those 3 definitions. And then we have number 4, where they have to have normal or stable lung function. Okay? So is that too demanding to have 4 criteria? And I have heard that from some groups. In my opinion, it's the last answer. It's not demanding enough. That we have to have a much higher standard to tell a patient with asthma that they're in remission than, again, just no symptoms and no steroid use, no exacerbations in the last year. All right. Now, the other thing that you won't see out there is, why can't you talk about remission if someone's just on an inhaled corticosteroid? Does it have to be severe asthma is the only way you can tell someone they're in remission? Okay. And so this is the only paper I can find that someone looked at it, and they looked at mild to moderate asthmatics. In fact, this is a study out of Tokyo. Okay, so it's a Japanese study. And so you can see here, it's in the middle here. So this is looking at 3-component, this is looking at 4-component. And again, look at the very high rate of remission that in fact, quote unquote remission that they're seeing in that population. And then this is their severe population that was on biologics. And again, it's fairly high, 30%, but again, you're using what I don't think is a very strict criteria. Okay, so the last thing I want to mention is the College, Academy, and ATS framework for on-treatment clinical remission. And the reason this came about is, in fact, a lot of individuals headed by Mark Corbett felt that these remissions, these definitions of remission that are being seen in the literature associated with biologics are misleading, that they really are not a higher standard than what is control. In fact, in some cases, I don't think there is good a measure as control. So this was a group then from these 3 organizations of pulmonologists and allergists getting together to at least try to develop a different framework and get talking, maybe looking at other effects as far as remission. So you'll notice here that we did no exacerbations requiring steroids and stable or optimized lung function. And again, using measures for asthma control, but the stronger measure for ACQ. And the other thing, all these other remissions, the papers that you read, remember, these control tests are only for 4 weeks, okay? And all they require is it being done once. So 4 weeks out of 52 weeks to show a normal value, okay? So we put in there that had to be done more often than that doesn't really tell us. And then the other thing we did is that we said we had to look at reliever use. If it's looked at in control, and we talk about like the rules of 2, can't use your reliever more than twice, then why shouldn't that be part of measuring remission? It should be much less than that, okay? That's what I think. Okay, also, we thought that if you're really in remission, you shouldn't be missing school or work from asthma, okay? I mean, that's what I think. And you shouldn't have to be on high-dose inhaled corticosteroids, okay? You should be able to decrease your medication, okay? Because again, we know that can be systemic side effects with high doses. So we added those things. Okay. So the other thing is, again, the FDA is not going to do this. And right now, GINA is not going to do it, though maybe in the future. So we felt it was important that the professional medical organizations get together and, in fact, try to come up with what we think is a definition that should be used out there in the literature. As I've already pointed out, there's a lot of different definitions out there, but the goal of what we were trying to do was come up with something that was higher than control, okay? And the other thing is that we realize, going the wrong way, that this is just a framework because this is not a validated instrument. It's a framework to get other groups talking, then hopefully, and in fact, there are some groups trying to get together. I'm working with one to try to get a unified worldwide definition of what remission is, and then let the pharmaceutical companies use it, okay? So that was the whole point of this. So where are we now? Right now, we're in control. Do we have any drugs that really lead to clinical remission? I'm not totally convinced of that. When one company was asked why they didn't follow our proposal, they said it would be too hard to do. Okay, so maybe it is. I don't know. It's just a start. So maybe there are patients that truly can get clinical remission right now. Of course, we're not anywhere near obviously complete remission and obviously no cure. Okay, so this is an evolving process. So anything you read out there or you hear out there related to remission, remember, it's not like control. We don't have a set definition. And so none of these are. So the whole point being here is we've got at least some consensus in the US, but it really needs to be worldwide. But then it needs to go through validation. It needs to go to refining. And then hopefully then we have a real definition that we can use to say that if you meet this criteria, then in fact your asthma is in remission. But I will not at this point in time tell any patient that I think they're in remission. I think I'm giving them wrong information. Okay, so in conclusion, because I saw the little red sign go up, this is, again, a concept in motion. So I don't want you to think, and that's what scares me out there, that people think that there are standards out there and this is what we should be following. It's an ongoing debate out there. I think the only thing all of us agree on is there shouldn't be any exacerbations or steroid use for a year. That everyone agrees with. It's everything else that we don't agree with yet. And again, it should be for at least 12 months. Also realize that, again, you'll see biologic medicines, again, some in the literature, 20 to 30% remission. But remember, again, that is, again, not the definition. It's not a strict definition, and it hasn't been validated in any way, shape, or form. But I don't want to come down on biologic therapies because I think they're great. For so many patients, it's made a world of good and it's completely changed their life with asthma. I'm just saying, I'm not convinced that we can call that remission at this point in time. So what we do need, as it states here, is a unified validated definition before we go out using the term remission in asthma. So I'm going to stop there, and there's my email address. No one can have my WheezMD email address. And I'll be happy to answer any questions. Thank you. I'll hold this.
All right. I know we have some questions because I saw the looks, the shrugs, the side eyes. Who's got the first question? Yes. Let me come to you. No.
Thank you. Thank you for all the information. A question, in our clinics, the providers, we went over, like you say, we hear here and there, some information about remission. So they've been using the 2 years period of not using an inhaler, not being limitation of any physical or activities they like, no ER visits, no hospitalizations for 2 years. And that's what we call in remission. So now when we go back there, what we should do.
Yeah, I mean, obviously if you have, and we know that spontaneous remission does occur. We know because I know we talk about, you don't outgrow asthma, but in fact, we do know, obviously there are children that completely do go into what we call remission and are completely off of medication as adults. They tend to be the milder children that were having symptomatology when you look at the literature. So, 2 years would be fine and you've got off medication. And so, again, it may need to be 2 years instead of 1 year. And I think that's why, again, all the worldwide allergy, asthma, pulmonary groups need to get together and really come up with a definition and then try to validate it and really look at it before we start using that, just throw that term out there, because I think it does an injustice to patients.
Dr. Blaiss, nice review. Have just a question for you. If cost, based on what you presented, based on if there was no cost issues involved, wouldn't it make sense the way we treat some of the autoimmune diseases to put everybody on the biologics first, and then the medicines just be rescues? You'd be much more effective in treating the cause of the problem instead of just trying to suppress the symptoms.
I don't know if we're treating the cause. So and again, we don't have any data right now, at least in my opinion, and you may know the data better than I do, that any of the biologics change the natural course of the disease. In other words, we don't have any data that once you stop the biologic, that in fact, the patient continues to do well without any problems. So I only know of one study out there with omalizumab, and this was a while ago, that dropped the patients after, I don't know if it was a year or two after they were asymptomatic, and half of them within the next year had exacerbations. So I'm not sure at this point in time that that starting them earlier will necessarily lead to, being able to completely come off of medication. We just need more data.
So,
Yes.
Dr. Blaiss, we have online questions. One of those is, if we were to have a single definition of remission for asthma, what would the health insurance do,
That's a great
in your
question.
opinion?
And that may be, it depends, again, it gets to that remission. Do we talk about remission, clinical remission on treatment? Or do we come up with the definition that in fact, we don't call it remission until they are off of treatment? The rheumatologist for rheumatoid arthritis is on treatment. So I think, in that regard, I think it's how we define what remission is. And if the definition that's determined over time is clinical remission on treatment, then I'm not sure that there'll be any problems as far as with the insurance companies, as far as continuing the treatment, because that's the way the definition is defined.
Yes, I'm Heidi Schmidt. I'm a PA in allergy in Phoenix, and we treat a lot of children early on for their severe atopic dermatitis, and we know those children, and sometimes for their EOE or both, and we know those children are at risk for persistent asthma. I'm just curious about your thoughts of how to be able to take these kids off of their biologics when their severe AD has now seemed to improve, especially if they don't have some of the other conditions. I just think sometimes we're probably covering up some of it, as we know it's similar information. So I'm just curious, because I want to be able to take some of these kids off of biologics safely. I know that's probably a long question, but I'm
Yeah.
just curious on your thoughts.
So unfortunately, right now, we don't have any studies, okay, that have really looked at weaning patients from biologics. I can tell you what other doctors do and what I've done in the past. And that is, if someone like with atopic dermatitis has done well for a minimum of a year, then I start going in longer duration between treatment and then kind of see how they do. Because there is a little data with that with nasal polyps. And so, and then again, if they have problems, I don't look at it any differently if we're taking about an asthmatic that's on inhaled corticosteroid. If they're doing real well for 6 to 12 months, they've had no exacerbations, rare use of a rescue medicine, then I'll try to lower their dose and then try to, in fact, wean them off. I mean, unfortunately, we know these conditions do this. And I tell patients that even if I'm decreasing your medicine, it doesn't mean I may not have to increase it back, because again, you may not stay under control that way. So I think that's what you have to explain to the patient, but I don't see any problem if they've been stable for a while to try to decrease the length of the medicine or decrease the concentration of the medicine and see how they do, because no one has those studies to tell you. Okay, thank you.
So much, Dr. Blaiss. Thank you.